So good. Welcome back, guys. I hope you enjoyed tea. But I think you must be having tea in between also. But a break is always good to digest whatever we have learned. I think the next session starts now, and the very first session is on ECG and X-ray in congenital heart disease. And we just don't do echo; we just have a before the data. Rohit Manoj is a very close friend of mine, and he is MD and DM cardiology from PGI, and then he stayed back. He is working as a professor of cardiology in the department of PGI. The great help is whenever I have a patient where I need help, intervention, patient cannot afford, be it a coronary intervention, be it pacemaker, be it electrophysiology and pediatric cardiology, all put together. He had been a great help. He picks up the phone any odd time and would respond in the best way possible. He is area of interest being device therapies in heart failure. He is also in electrophysiology and pediatric cardiology. So he likes all algebras of cardiology, electrophysiology and pediatric cardiology. And he is currently on vacations and gone back to his native place. And we would run a recorded video for him.
Uh, Good morning, all of you. It's my great privilege to be part of this important meeting on children with heart disease, and I'd like to thank organizers for giving this opportunity. My first talk is on ECG and X-ray in cyanotic congenital heart disease, which is rather tough to cover in 15 to 20 minutes. But I will try and stimulate all of you that they are forgotten but very useful way to help and recognize urgency or diagnose and then refer to appropriate center. We all know that cyanotic congenital heart disease have been classically described into divided into increased pulmonary blood flow, what is called a child who presents with a cyanosis, and CCF, often called admixture lesion or TJ physiology. Another group of children who present with cyanotic heart disease with the decreased pulmonary blood flow is a PS physiology, or what is called top physiology, and Eisenmenger physiology. We are not going to talk, it's a very limited talk, so we are not going to discuss about acyanotic congenital heart disease. And they also have an important role in ECG X-ray, but that is not my topic for the discussion. So to if I see a child with cyanotic heart disease, first need to decide, is it reduced pulmonary blood flow or it is increased pulmonary blood flow. And as I told you, the most critical thing in neonate and infancy is increased pulmonary blood flow, so-called TGA with intact septum or TGA with VST, TAPVC, persistent trigger. They are TGA and TAPVC are urgency. If you diagnose a child with, say, 2 weeks old child with cyanosis and CCF, and he has a gross failure, one is very worried, and this is, we simply cannot wait, and it is likely that we are dealing with either TGA with VST or TBC with some significant problem, and this child needs urgent attention. And another group of condition is a reduced pulmonary blood flow, where we deal with the tetralogy fellow, or what is called top physiology, a child who has a history of cyanosis, child who has a history of spell or sweating, and he does not present with the CCF. There is no CCF, failure. So in this group of condition, we typically see tetralogy fellow, tracheobronchopathia, DORV, or we can say single ventricle PS, truncus arteriosus VST PS, or any condition which has a large VST with severe pulmonary stenosis. So to interpret X-ray, it is very important to see X-ray, read the X-ray. On the right side of the structure, we see first thing is SVC. You can see the arrow. This is a SVC, and this is a right atrium is there, and then the IVC. On the left hand side of the shadow, you can see this is aorta. This is the pulmonary artery, and this is the left ventricle. We do not see right ventricle in AP view, and between the pulmonary artery and LV is a LA appendage. This is how the X-ray would, if you have to draw diagrams representing the structures, this is how they would look like. This is the RA, this is the SVC, this is the PA, and this is the RV, and this is how the LV and aorta goes like this. So, reading X-ray is a typical diagnosis. X-rays are rare. One must remember that, and it must be interpreted with a backdrop of clinical diagnosis. You have to have a clinical diagnosis. You simply cannot read the X-ray and then give the diagnosis. So, we will try and understand those in this thing. Always proceed systematically. Give due importance to lung field equally, whether a decreased blood flow, increased blood flow, any pneumonia, or some abnormal shadow is there. So when we see child with a cyanotic heart disease, it is important to find out what is the situs, what is the cardiac apex, what is the heart size, is the temporary enlargement is there, where is the aorta, and which is L pose, D pose, and what is the pulmonary vascularity, increase or decrease, and we finally see lung and then bones and soft tissue. So you can see in this X-ray that patient has apex is pointing towards the right. So one is this is not normal, and we would say this is a dextrocardia is there, and you can see in this X-ray very clearly. We are unsure about the apex. You can say mesocardia, but you can very clearly see the stomach bubble normally is on the left side, but has come on the right side. So situs inversus is there. So this is important. This is a dextrocardia, and this is a levocardia, and this is a situs inversus is there. So can I make a diagnosis of situs inversus X-ray? Yes. Look at these patients. Normally, the precordial complexes in ECG, we see good complexes V1. As you increase from V1, V2, V3, V4, V6, progressively R wave progress increases. But you can see here very clearly that the voltage is maximum in V1 and very least in V6. This very strongly suggests that patient's heart is positioned on the right side, and this is a typical ECG suggesting you or informing you that heart is on the right side. Other clue to say the situs inversus is that look at the P wave. P waves are inverted in lead 1 and AVL that suggests situs. This is a typical ECG of situs inversus dextrocardia. What about this X-ray? You can see that the heart is positioned on the right side, but the left side of the lung is markedly hyperinflated. So this is a dextrocardia because of the problem with the lung. Hypoplastic right lung is causing this problem. So coming to the classical X-ray pictures or reduced pulmonary blood flow. In a reduced pulmonary blood flow, what is called top physiology, we get cyanosis, we get squatting, we get spell, and we get no history of cyanosis. Typically, the patient's heart is normal size, cardiomegaly is not there. Lung as oligemic. So how to describe oligemic lung field? You can see this pulmonary artery is empty, or what is called pulmonary bay is empty. You can say that oligemic. And more importantly, divide the lung field into 3 pits: medial, middle, and lateral. And if you see that after the middle and lateral part is empty, I cannot see any vascularity. So very strongly suggestive of decreased pulmonary flow. So pulmonary artery bay is empty. The vascularity middle and lateral is empty, indicating markedly reduced pulmonary flow. So this is a typical example, and you can see this is the apex or RV, it's upturn. What is called core and boot-shaped heart is there. So this is a typical X-ray of tetralogy of Fallot. On the other hand, if you have an increased pulmonary blood flow with cyanosis, they are called classically described as TJ physiology. They generally have a cardiomegaly. They have plethoric lung field. We see end on muscle. Can you see this white spots? These white spots. Along with that, you will see bronchial there. So the white spots, these are bigger than the adjoining bronchi, and then you will definitely have increased blood flow. And I can see the vascularity extending beyond lateral third. That is very strongly suggestive shunt more than 1.5:1. And they generally present very early TJ physiology, I said, in infancy. So you can see this is called boot-shaped heart. You can see this typically it is an X-ray of tetralogy of Fallot, and here you can see this X-ray is of tracheus atresia. Among the top physiology, tracheus is there. So why tracheus atresia? Why not this? Besides the fact that patient has a pulmonary artery bay is empty, pulmonary artery, the RA border is almost receding. So when you have a low flow physiology, if you have a receding RA border, one strongly suspects patient is having tricuspid atresia. This is a typical X-ray of congenital corrected TGA, CCTGA. So why it's so? You can see that this is called L pose aorta. Here you can see this is a this position is a aorta, is a left forward. Normally aorta will go like this and come like this, but here the aorta is going like this and this. So L pose aorta is very strongly suggestive of congenital corrected TGA. So this is a typical ECG of, we discuss X-ray of TOF, and why so? If I see a child who has cyanosis, this is an 8-year-old child with a TOF, this child with cyanosis, and if I see the patient has a pure R wave in lead wave 1, which suddenly become RS transition, RS, this is called transition, S wave appears in V2 is called transition, and if I see that, and blue child with a normal right to axis, very strongly suggestive of TOF physiology, or what is called classically seen in typically tautology of fellow. And here, unlike the previous, this is in this slide, you can see the pure R wave become RS button V2. So if the patient has an intact septum, you can see the difference between the previous slide and this slide. The patient has a pure R wave in lead V1, so it persists V2, V3, V4, V5, V6. There is no transition. The pure R wave persisting, ST depression is persisting. So this is a suggestive of RVH with intact septum, and very strong probability that this patient will have pulmonary stenosis. So you can see the difference between the TOF and the pulmonary stenosis ECG on ECG. And we also saw the X-ray of tricuspid atresia. So can I make a diagnosis of tricuspid atresia in ECG? Yes, I can make diagnosis. So this is a typical example of tricuspid atresia, where you can very classically see a cyanotic child with a left axis deviation, very strongly suggestive of tricuspid atresia. You can see the V1 is positive, and predominantly QRS complex is negative suggestive of left axis deviation first. So any child, cyanotic child with a left axis deviation, think of tricuspid atresia. Other clue is that patient has a counterclot lobe. What is it called? We see normal QFCN, small QFCN 2, 3 AVF. But if I see QFCN lead 1 and AVL, it is called counterclot loop. That very strongly suggestive of inlet VST, typically seen in tricuspid atresia. Also, I can see tricuspid atresia RV is hypoplastic. So you can see deep SV suggestive of a good LV forces and poor RV forces, very strongly suggestive of. So typically tricuspid atresia ECG would be patient would have a left axis deviation, counterclock lobe, and a good LV forces in V1. This is a typical ECG of the patient. You can see the lead 2 of a patient of congenital corrected TGA, classical ECG. Any child who has a cyanotic blue or is cyanotic who has a bradycardia, suspect congenital corrected TGA. And the clue would be the patient has a CHB. You can see in lead 2, the QRS is there, this is the P wave, this is the P wave, this is the QRS wave. So complete AV distribution is there, very strongly suggestive of a complete heart block. Important to remember that normally we do not see QFs in lead V1. If you have presence of QFs in lead V1 and absence, normally small QFs are present in V5, V6. If you are absent in V5, V6, right, with presence in QV wave with CHB would indicate patient has a ventricular inversion, and there is a CHB very strongly suggestive congenitally corrected TGA. Some exceptions to this rule are: this is a child who has a very loud murmur, relatively asymptomatic. What is there in striking on X-ray is a very markedly aneurysmal right pulmonary artery. This is a right pulmonary artery. So if you have a blue child or loud murmur with abnormal vascular study in a pulmonary, generally is pulmonary dilation, and this is strongly TOF with absent pulmonary valve. Is that typically seen in TOF with absent pulmonary valve? This is a child who has a TOF. You can see that X-ray is very strongly suggestive of TOF, but this is a bit more than TOF. You can see the patient has upturned apex and pulmonary artery is empty. So one would definitely make TOF. Then what is odd? One expects the patient has a TOF to have a decreased blood flow, but that is not the case. You can see the vascularity is markedly increased, and you can see the vascularity extend lateral third of that. So if I have a child X-ray which is TOF like physiology, but vascularity increase, our patient is likely to have a marked collateral, and so very strong possibility that patient has VST with pulmonary atresia or increased MAPA is there. So this is a typical X-ray of the patient of in increased blood flow. We expect patient to have a cardiomegaly, and patient have an increased vascularity. So this is it, and striking, if the child is blue with cardiomegaly, this pedicle, what is called, we describe as pedicle narrow because of atretic thymus and anterior posterior relation of great vessels is called narrow pedicle, and with this one is very difficult to differentiate between VSD versus different. But you can see that patient is pulmonary artery is a bit empty, and here VS is a bit more prominent. So this X-ray would very strongly go in favor of TGA physiology, and you can see probably this is better X-ray to set typical TGA. Egg-on string or egg-on side appearance, egg-on sign with a narrow pedicle, very strongly suggestive of transposition physiology is there. Another typical X-ray of congenital heart disease is the figure of 8 appearance, typically seen in TAPVC. 3-year-old child referred with a diagnosis. So simply check the saturation. You can never have a normal abnormal saturation in a simple ASD. If you have a ASD with saturation below 95%, that's 92 to 90, 85%, suspect something else, the complication. And if you have X-ray like this is the right atrium, this is the dilated SV, this is a vertical vein, very figure of 8 or what is called a snowman appearance is very strongly suggests diagnostic of supracardiac TAPVC is there in this situation. In the newborn period, another interesting X-ray all the pediatrician must know is the patient has a whiteout lung field or what is called it's difficult to differentiate with a meconium versus pulmonary venous hypertension. If I know the child has a term baby, right, and if he is very CCF and distressed and he requires ventilation and there is no mechanism, so ground glass appearance in term baby would suggest me strongly suspect infradiaphragmatic TBVC. On the other hand, if the preterm baby, I cannot rule out meconium aspiration or hyaline membrane disease is always will remain a possibility. But in term baby, I would suspect very strongly obstructed TAPVC. Another typical box appearance, what is called box or money bag appearance, is gross cardiomegaly, decreased pulmonary blood flow. A related asymptomatic child is a typical X-ray of absence anomaly, and is there what is box-shaped heart is very strongly suggestive of absence anomaly. There, enlarged heart, enlarged RN, pencil-shaped margins, normal aorta, and pulmonary oligoemia is there. So can we confuse something else? Yes, we can confuse with pulmonary stenosis, RD dysfunction, but I will, if I'm not sure if I have the X-ray, I will show you that. This is a typical ECG of absence anomaly. You can see pure tall peak P wave, R wave in V1, and inferior lead, and RVB with a strong blue child with a tall prominent P wave, and he was called Himalayan P wave, very strongly suggests absence anomaly is there. And this is the X-ray of Eisenmenger syndrome. In that, the patient has a PA dilatation, normal cardiac sizes, RPS dilated, but suddenly you can see peripheral pruning, we call peripheral pruning. Middle laterals are cut off. So very strongly severe PH. One of the diagnoses will be Eisenmenger syndrome. On the other hand, we did discuss about the gross cardiomegaly, and this is the gross cardiomegaly with the PS with RV dysfunction and the marked oligomer. The difference between the absence anomaly here you can see is that there is no pulmonary artery dilation, while in PS you can see the patient has a prominent pulmonary artery with the vascularity is reduced is there. So with this ECG, we discussed the ECG of severe PS with intact septum, pure wave, no transition, suggests the patient has an intact septum. To summarize, always ask for clinical diagnosis, and so before you read an ECG and X-ray will be extremely useful in making diagnosis. Thank you for the opportunity. I hope the X-ray was useful today. Thank you.
Wonderful talk by Dr. Rohit Manoj, but he is not available currently, and